physical examination of the newborn infant is an essential component of the overall assessment process. Other essential components include obtaining the family health, maternal and labor and delivery history, the gestational age assessment of the neonate, and the evaluation of the neonate's biophysical, clinical, and laboratory data obtained prior to the examination. This videotape will focus on the actual physical examination process. An examination will be demonstrated on both a full-term and preterm newborn. During the exam demonstration, normal physical findings and common variations will be discussed. However, the emphasis of this program will be on the components of the examination process and the techniques for examination. There are 5 basic techniques used when performing a physical examination: observation, auscultation, palpation, percussion, and transillumination. In the normal or well newborn, the techniques of observation, palpation, and auscultation are routinely employed. Percussion is used most often in older children and adults and will not be discussed in this program. Transillumination may be used in the neonate to evaluate for free air in body cavities such as the chest, to help differentiate fluid-filled cavities from solid tissue such as in the scrotum or over the anterior fontanelle, and to help locate arteries for puncture. Other methods of evaluation are used in the neonate, such as the sense of smell. Taking body using the use of the ophthalmoscope will be discussed under examination of the eye. The physical examination presented in the film will focus on observation, auscultation, and palpation of each body system. In general, the practitioner must be opportunistic in the approach to examining a newborn. Since newborns will cry readily when disturbed, it is important to perform the components of the examination that require the infant to be quiet first. Therefore, we recommend that the examiner carry out a brief period of observation without manipulation first. This should be followed by auscultation of heart, lung, and bowel sounds, since it is necessary that the infant be quiet for accurate auscultation. We recommend then that the examiner proceed to palpate pulses and perform the abdominal exam, which may result in an agitated infant. During these initial steps, the examiner should take note of the infant's state, tone, and spontaneous and elicited muscle movements to gather data regarding the neurological system. This will allow the examiner to compare neonatal responses as the neonate progresses through various state changes. Once these initial steps have been completed, the examiner may modify the exam to meet the needs of the infant. The most organized approach is to proceed with a head-to-toe flow, skipping those areas that have already been examined. In this program, a complete examination of a full-term newborn will be demonstrated first using the head-to-toe approach. More detailed discussions of technique, common variations, and anatomic landmarks will be incorporated into this section. This will be followed by an examination of a preterm neonate, using a more realistic sequence for a newborn. For the full-term infant examination, 2 infants will be used: a 5-day-old female and a 3-day-old male infant. Views of both infants will be used interchangeably for this demonstration. To begin the exam, the practitioner will observe the neonate in the resting state. You will note that the neonate is pink centrally and peripherally. This infant is lying in a fully flexed posture, which is normal for a full-term baby. The infant's respiratory effort is not labored. There are no audible grunting sounds. After opening the shirt, you will note chest movements in greater detail, as well as the activity of the precordium. At this time, the practitioner will begin the head-to-toe examination. To examine the head, the practitioner initially evaluates the shape and size of the head relative to the body. The practitioner measures the occipital frontal circumference using a non-stretchable measuring tape. The measurement is then plotted on a standard growth chart to determine if it falls within the normal range based on gestational age. The shape of the head may vary greatly depending on intrauterine positioning, mode of delivery, and degree of molding. To examine the head more closely, the practitioner takes the head in both hands and inspects the scalp and hair. If the infant has a large amount of scalp hair, it is particularly important that all areas are thoroughly inspected so that lesions are identified. The most common form of trauma to the head is a caput succedaneum. This is edema of the scalp, usually located over the presenting part of the head. A caput is noted just after birth, pits on pressure, and typically crosses suture lines. A cephalohematoma is a collection of blood underneath the periosteum, which lines the skull bone. A cephalohematoma generally has clearly demarcated borders coinciding with the skull bone that it overlies. A cephalohematoma may not be evident right at birth. Suction devices to assist delivery may cause trauma to the head. The imprint of a Kobayashi suction device is demonstrated on this infant. A scalp abrasion is demonstrated here, and a laceration of the scalp is noted on this infant. Next, the fontanelles and suture lines are palpated. The cranium is composed of 7 bones, which are soft, and usually separated at birth. The sutures separate the 7 cranial bones. The coronal sutures extend from ear to ear, separating the frontal and parietal bones. The sagittal suture separates the 2 parietal bones, and the lambdoidal suture separates the parietal bones from the occipital bone. The metopic suture extends midline down the forehead, separating the 2 frontal bones. The sutures are palpated along their full length and described as normal if they are approximated and mobile. Mobility is assessed by placing 2 fingers on either side of the suture and pressing down alternately. Bone edges on either side of the suture should move. Sutures may be split up to 1 centimeter or slightly overlapping, depending on the degree of head molding. Rigid, immobile, or widely split sutures require further evaluation. Most infants are born with 6 fontanelles, but the most prominent are the anterior and posterior fontanelles. The practitioner palpates the anterior and posterior fontanelles, noting size and whether the fontanelles are flat or bulging. The size of the fontanelles varies greatly, depending on the degree of head molding. The anterior fontanelle is measured diagonally and varies from barely palpable to 4 to 5 centimeters across. The posterior fontanelle is smaller than the anterior fontanelle and may be barely palpable with the fingertip. The face is examined next for shape, symmetry, lesions, and movement. Asymmetry of the face may result from injury to the 7th cranial nerve. The 7th cranial nerve is distributed along the face and in front of the ear. Forceps trauma is the most common cause of injury. You will note that facial movements are symmetrical on this infant. 4 components should be evaluated. The nasolabial fold should be present. Both eyes should open and close. The corners of the mouth should move, and the tongue should move on both sides. All 4 components are present in this infant. The eyes are examined for placement and size of the palpebral fissure. The palpebral fissure is the elliptical space created when the eyelids are open. The distance between the outer canthus of both eyes can be divided equally into thirds, with 1 palpebral fissure length fitting between the 2 eyes. Small palpebral fissures, widely or closely spaced eyes, and eyelid defects may all be associated with syndromes or chromosomal anomalies. An epicanthal fold is a fold of skin extending from the upper to the lower lid on either side of the nose. Epicanthal folds are common in Asian infants, but may suggest Down syndrome in other ethnic groups. To examine the eye, the infant may spontaneously open the eyelids, or the examiner will need to open them. The practitioner first inspects the iris, which should completely surround the pupil. The sclera should be white unless the infant has experienced a conjunctival hemorrhage during the delivery process. The practitioner next uses the ophthalmoscope to assess the pupil response and red reflex. The ophthalmoscope is set on 0, and the white beam of light is directed at the pupil while the practitioner looks through the ophthalmoscope with 1 eye. The practitioner should observe that the pupil is round and will react by constricting to the light source. a clear, round red color, the red reflex, should also be noted. The ear is examined for shape, position, size, associated anomalies, and for drainage. An otoscopic examination is not performed in the newborn period. Pits or skin tags or other external abnormalities should alert the practitioner to look for other anomalies and to assess hearing function. To evaluate ear position, the tip of the auricle or pinna should cross the eye-occiput line. The angle formed by this line and the long axis of the ear should be almost vertical. The nose of the neonate should be symmetrical and placed in the facial midline. While its shape and size may be familial, it will appear flatter than that of the adult. When inspecting the nose, there should be no visible movement or flaring of the nares with breathing. There is no flaring noted on this neonate, and the nasal septum is centrally placed. The lower turbinates are visualized. To assess patency of the nasal passages, the examiner may occlude each nostril while listening for respiratory sounds from the opposite nostril. If any obstruction is suspected, a soft 5 French catheter should be passed through each nostril to establish patency. The examination of the infant's mouth and throat should begin with inspection of the lips and mucous membranes. They should be pink and slightly moist. A bluish color around the mouth, circumoral cyanosis, may be present and is normal right after birth. The mouth should be assessed for size, shape, and lip fullness. Inspection of the inside of the mouth is most easily done with the infant crying or with a tongue blade and light source. Probing of the lips and gums usually results in spontaneous opening of the mouth. The hard and soft palate, gums, mucous membranes, tongue, oropharynx, and uvula should all be visualized. The hard and soft palate should be smooth and without clefts. Small white accumulations of epithelial cells called Epstein's pearls may be visualized on the hard palate or gums. They are a normal occurrence and will disappear spontaneously. Although not present on this neonate, bluish-white swellings called mucoceles or ranulas may be present. These represent benign mucus or salivary gland retention cysts and usually spontaneously disappear. Infrequently, natal teeth may occur, usually at the position of the lower incisors. This neonate has 2 teeth that have not yet erupted through the lower gum line. The presence of excessive secretions should be noted and is considered abnormal. If there is any question about the patency of the esophagus, an orogastric tube should be passed to the stomach. At this time, the rooting and the suck reflex may be assessed. The rooting reflex is assessed by stroking the cheek outward from the corner of the mouth. The suck reflex may be assessed with a pacifier or gloved finger.